Okay, well, let's get started. We are really excited to host this webinar tonight. We have a lot joining. Good evening. We have a lineup of some very passionate and wise educators, and this is all about you, the student wanting to pursue a career in general surgery. Before we get started, I wanted to introduce my co-chair, Hope Jackson. She's an associate program director at University of Michigan. She's also the program director for the bariatric program at University of Michigan, and she'll be helping us with some of the pre-submitted questions and questions that you guys go ahead and put those into the chat during any time throughout the entire webinar. The other kind of housekeeping is we have set aside at the very end of this webinar a Q&A session. So you'll also have time to add more questions along the way, because I think as you hear some talks, some of your questions will be answered and generate new ones. I want to thank SAGES and the RAFT committee. It stands for Resident and Fellowship Training Committee, especially Dr. Ivy Haskins, who invited us all here, and supported by Betty, who basically did a lot of work behind the scenes to make this webinar possible. So without further ado, I was going to start with just telling you a little bit about SAGES after showing you the schedule, which you all have access to. SAGES is, I'm very biased, but it's definitely my go-to society. It's a general surgery society, has more than 7,000 members. Our vision and mission is stated here, but it's a society where you can really get involved earlier on in your career and get involved in committee work. And most importantly, it's a really fun society, and it becomes a family after so many years. I think most of the panelists on our webinar will agree with me. The annual event is going to be in Vegas. And if you join before then, you get a pretty significant discount. You'll be a candidate member. You have access to a lot of education resources. SAGES is known for putting out really high yield education content. And being one of these are these free webinars. And when you become a surgery resident, you take a test called the ABSITE. And so the webinars are ABSITE focused for 2 or 3 sessions around that time. So there's a lot to take advantage of in addition to face groups. So again, you can become a candidate member as a resident. And here's some of the free upcoming webinars that you may be interested in. Again, I think this becomes very relevant to you as you progress throughout your general surgery residency. All right, so without further ado, I'm going to introduce our first speaker, who is Dr. Jonathan Dort. He's a vice chair of education, in addition to a longstanding program director at Inova Fairfax, Virginia. He's also the chair of the mentorship committee for all associate program directors, and has mentored me personally and some others on this panel today. So again, I'm really glad you joined us, Dr. Dort, and looking forward to what you have to tell us about becoming a competitive applicant for general surgery.
Thank you very much, Dr. Peterson. I appreciate it, and I appreciate the invitation to be here. I'm going to share a slide. Can you all see the first slide? Can
Yes.
everyone see it? Okay,
Yes.
thank you. All right. Let me start by congratulating you for being here. Just considering surgery as a career, I think is something that I would do again. I tell everyone who will listen to me that I love my job. I love taking care of patients. I love operating. I love everything about surgery. I love teaching. I love the whole environment, and I would do it all again in a heartbeat. I think this is just the very best thing that you can do with your life. If you're surrounded by people that tell you if there's anything else that you think you could do, do that. Just smile and nod and feel a little sorry for them, because this really is the most rewarding, but also the most challenging professional decision and career choice that you can make. So, what goes into making that career choice? Making the decision before you talk about all the strategies, before you talk about all the pieces that have to go into an application or go into being an applicant, the first thing you have to analyze is you. And the first thing you have to analyze is what it is you're walking into. So the best thing you can do is do your research. When you get to your surgery rotation, talk to everyone, talk to residents, talk to attendings, talk to people who are in the profession, ask them about their experiences. You have a few weeks in each of these first rotations to learn not just the clinical information, the operative information, but about the profession itself. And the first thing you should do is utilize all the people around you and ask about their experiences and ask what it's like to be a surgeon. And you should get some very honest answers, and you'll get a wide variety of answers, but you know yourself best. And so maybe what challenges some people is something that won't be an issue for you, but maybe something that people handle well. You know yourself well enough to know that that might be a challenge. So it is important to understand all the pieces of what it means to go into this profession and know yourself, because making this decision to go into surgery is a lifelong commitment. And it is a commitment to do this at a level that is elite, that demands excellence. You are entering a profession where the most amount of perfection is expected, really where it's the least possible. But you have to always strive for that perfection, and that requires a lot of sacrifice and a lot of commitment. I joke with my residents and I tell them my worst days in attending is still better than my best day as a resident. You go through this residency experience that is a little bit artificial as far as what your real life is going to be like, but it's very necessary. If you think about where you're starting now to where you need to be when you finish a residency program to independently take care of people, that's an immense learning curve. It is a learning curve that will challenge you mentally, physically, emotionally. The outcomes, the burden of the outcome of people who have trusted you and you developing your knowledge and your skill set to get to that point is a big responsibility. It is something that you need to look inside your heart and say, this is what I want to do. This is what I know I can do. And if you make that decision, it is, I go back, the most rewarding thing. You will never have to finish a day, look in the mirror, and answer the question, what have I done to better everyone around me? You will always be able to answer that question. So with that, make sure you know yourself well. Make sure when you have your experience with the surgical residents, the surgeons around you, that you can make the honest appraisal and assessment that this is a life that you can live, that this is a commitment that you can make. And how do you ultimately know? I find that most students, when they finish their rotations, they always go down to about two or three possibilities, and usually two that they're wrestling between. And there's always one that you find yourself talking yourself into, and there's always one that you sort of talking yourself out of. Always go with what you're talking yourself out of, because that's your brain and your heart arguing. Your brain knows what's sensible, but you have no passion for it. Your heart knows what may not be sensible, but you have all the passion for it. And passion is what will carry you through a profession. So if you're talking yourself out of it, you know it sounds maybe a little crazy to you, but it's what you want to do. And that's how I would run my decision. Once you've made that decision, now you have to put the pieces together. And it is such a daunting path. And those of us who are on the other end of it, who are not only coaching students, but running programs and having to go through applications and having to talk to people and having to partner on this process from the other side with you. We know how stressful this can be. We know how everything seems like it has to be strategized and it has to be figured out. And I have to say this to this person. I have to do this. I have to appear to be that. And it can get very complicated. I want to try to simplify that for you. And that is to put it into pieces of things to think about. And I think that's what all of us are going to try to do today for you for different parts of what this application is. So the first few parts I want to describe to you is what happens clinically during your rotations and as a student. And then we'll talk a little bit about mentorship and a little bit about some of the academic piece that you have to put together. Clinical performance. You have a few weeks. Every school does it a little bit differently. Every school is structured, but generally have somewhere in the 6 to 8 week range to be exposed to the surgical sciences. And some schools give you options of giving you choices or at least taking requests. Some schools just assign it. Usually there's a core general surgery or a type of core general surgery rotation and one that's a little bit more of a subspecialty or elective. Again, there's a lot of variability to that. But however you get there and whichever part of it, make every day count. Make what you do count. Soak it all in. Teach yourself. This is your chance not only to be you're auditioning careers as much as you're auditioning yourself to the residents and to the faculty there. So be present. Every opportunity you get, be there. Nobody tells if our students have duty hours as well as our residents. I think a lot of schools have that same piece, and nobody's telling you to break duty hours and sort of the medieval hierarchical thoughts of surgery, and you have to be there all day and all night. That's really gone away. It certainly is an intense, long experience, but nobody expects you to just stay there all day and all night. And if they do, those probably aren't the mentors you should be talking to. We want to be able to give you a real but human experience, but you have to be present. There are ways as a student to make sure you're available to everything, and there are ways to only show up to what you're required to. And people are very clever in figuring out how they don't have to do anything beyond what they're required. If this is what you want to do, you have to go seek out the experiences. You have to show that interest, assuming that interest is genuine, and that assumption is made because you're here tonight. And if it is, look for every opportunity. Ask him if you're not nothing's happening on your team. Ask him if there are things on other teams that you may not get a chance to see as a student because you're not assigned. If you can go scrub on those cases or do a clinic with someone you may not get a specialty. Be enthusiastic and aggressive about seeking out every experience that's within the rules and within the hours of the rotation you have. When you're rounding on services, you don't have to know the answer to every trivial question that is asked of you. Sometimes questions are asked because they know they want to teach you something. What they will expect you to know is your patients. Know your patients well. Know their history. Know why they're there. Know all the tests and the results that have been done. Know their medical problems. Know about those disease processes. Know the solutions. Know the operations related to them. They definitely will expect you to know everything about your patient, them personally, and the problem list and the potential therapies that are available. So that it should be something you spend some extra time on. There is a balance between assertiveness and respectfulness, and you can do both. There is a way to do both. Be engaged, be positive, ask questions, and when you're in an operation, have a good sense of when the right time to ask questions and when the right time is to let things go. But nobody or should not get on your case for being engaged and for participating and for asking. So be that person, show them that interest. And we agree that that interest is not false, that interest is real. When it comes time to setting up your electives, when you finish your core rotation, try to do well on the shelf. Your life for a while is going to be a series of standardized tests, and that's just a reality of life. And some people are really good at them, and some people have to work at them. It's worth working at it. It's worth doing your best. It's a whole nother topic to discuss the scores and what they mean and strategizing around them. But basically, just study, learn the material, and do your best. When you're looking to set a schedule clinically, get experiences and things that are going to make you the best intern possible when you show up on July 1st. Take the experiences that you have. If you want to dive more into those, Or if you want to find services that you haven't been on and experiences that you want to add, that's very important too. Most schools have specific requirements for your fourth year time. Usually there's an ACE involved, there's an ICU involved, there's an ER if you haven't done it as a third year. But most schools will give you a lot of leeway in what you choose next. And you should choose things that challenge you, things that you can learn from, things that will give you skills to move forward. It's the whole concept of this is your last chance to relax and take it easy. Uh, I'm not saying that you have to burn yourself the whole time. Certainly, you're allowed a trip. You're allowed a little bit of decompression time, but really make that last year count, not only for your ability to show up as an intern, but when you're applying and when program directors look at your transcripts, they're looking to see how you spent your time, where you were engaged, what you did to better yourself. Program directors want the most prepared, most well-informed and ready residents to go. And your best shot at doing that is to give yourself the best experience possible. So really, really get aggressive with the experiences that are available to you and learn everything you can and put yourself in situations where you avail yourself to all of those available activities. And it'll make you a better resident. It'll make you a better applicant. Program directors will pay attention to that. So once you have your clinical activity set, once you have not only your um, clerkship time, your elective time, how you schedule, how you spend that time, and the way you spend your time in the elective should be exactly the same as the clerkship. You'll get assigned patients. You need to know those patients cold. You need to know everything about their diseases. And then, of course, reading about the subjects in general. Really, really focus that effort to make yourself as knowledgeable, not only about the information, but about the pathways. And as you see more and more patients, you start to develop the skill set of making decisions and always have a plan for an attending. Always, when you talking to your chief resident or even your junior residents or your attendings, formulate in your mind what you would do for that patient. And even if you're not always right, everyone around you would much rather see that you are trying to make the effort to put the pieces together, to look at the possible algorithms and that you're formulating a plan. They fully expect to correct you. Nobody expects you to get this perfectly every single time, but the fact that you've made that effort to create a plan is what they want to hear. Once you go through your clinical time and you've had that set up, you start to look at, well, maybe I'm really ready to start this application process. Who do I talk to? I find that so many students are so under-mentored. And by under-mentored, I don't mean that you're very well surrounded usually by people who have a lot of opinions about training, about what you should do, about how you should do it. I'm talking about real mentorship, which makes you the focus of the conversation, getting to learn you, getting to learn what you want out of this, what you're looking for, and then how to get there and how to strategize. So my first advice to you about mentors is have more than one. Have as many mentors as you can put together because each of them will add some different dimension to the answers with the answers of the questions that you're looking for. Sometimes they'll be able to give you similar answers and shore up your confidence about an answer. Sometimes they may not give you the same answer. Sometimes you get a difference of opinion. And the way you should settle that is knowing yourself best because you know what is doable, what's not, what you like, what you don't like, what you're looking for. And that can be everything from where to apply and what is reachable for you and what you should have in your application to do that. There's no shortage of the people willing to give you those opinions, but you have to seek out the people who are really going to have your best interests. And you can tell that by the way they answer your questions. If they make their answers learn, it's the same educational tool. If they make them learner focused, meaning if the answers are tailored to what you want and what you're looking for, that's valuable mentorship versus the you everyone should do this because everyone is not the same. And that advice right away should give you a little bit of caution. So get as many opinions, get as many thoughts that you can about how to start putting the pieces together for this. I put a little bullet point that says aligning agendas with your dean. And deans have, they are the start of the team that you have to try to get you to the next level. I caution people with deans a little bit because deans want everybody matched. And that is a very noble goal to get everybody matched. But your goal is to get matched the way you want to be matched in the specialty you want to match in, at the place you want to match at, with the type of program that you want to match at, with the vision of the future beyond that you have. And so while the advice you get to just match, like, apply to 1,000 places or make sure you have these places on the list, or uh, maybe you shouldn't be a surgeon, maybe you should be a pediatrician. These are exaggerations, obviously, but those are all things to match. You know yourself best. You know what you want, and you have worked hard to get to this point, and you're at the point of your career where you're allowed to say, "But that's not what I want," and stick to what you want. So make sure that they align themselves to your vision and not the other way around. I mentioned that not everyone's advice is pertinent just for the examples that I gave you. That it if everyone says X program is the best program and that's what you should be in, X program may have research years that you don't want, or X program may send you across the country to different places and you want to stay put, or X program may not be a level one trauma center and that's what you want to go into. So again, advice is great. It's kind of them to give. You absorb it all, you take it all in, but ultimately don't deviate from what you know deep down to be what you want to be. And then use your connections. This is sort of the snarkiest bullet point to have on here. My program director used to say to me, remember in this process, it's not who you know, it's who I know. And I thought, wow, what an arrogant statement. And I realized it wasn't really arrogant at all. And it's very much the point that it's just that it's a small community, the surgery world, regardless of specialty. You find that people know each other, people train together, people know things about programs and about leadership changes. People know what programs are like. Just so when I say use your connections, do your research, talk to people if you know someone trained at the University of X and you're looking at the program at the University of X, go ask them for a meeting, ask them about their experience there, ask them what they know about it, and get that information. You have to do a ton of research, make massive Excel spreadsheets, because you won't remember every single detail. But make sure that you tap as many of those connections and as many of those people for information that you can. Scholarly work. How much research do you need? Do you need research at all? I think this is where the answers can get a little bit variable. I think a basic, safe answer to tell you is do something. I think even the most I never say there's no such thing as a non-academic program. Every residency is an academic resident. Everyone does scholarly work. Everyone goes to podiums and publishes. But there are places that definitely everyone does their 2 years of research, and there are some places nobody does 2 years of research. The places that are very research heavy want to see a lot of research. They want to see a lot of publications and presentations. And there's some places that just want to know that you've participated, that you know the process, and you at least have some comfort in the scholarly work process of how you go to an IRB, project design, data collection, data analysis, writing, or presenting. And so programs will be highly variable. Look at their websites, ask questions, go to their information sessions, get a sense of the places that you're most interested in, get a sense of what they want from you, and you can't start too early doing that. Seek opportunities. You may say, all right, I'm ready to do some research. Where do I turn? Go sit down with the clerkship director. Go sit down with the program director. Go sit down if someone is the head of research in your department. Go ask them who has projects, who has the best track record of being a mentor, of being engaged in the process all the way. You don't want someone to just hand you an idea and then their next comment is, tell me when the paper's written. You want someone who's going to guide you through, who's going to give you opportunities. And by please only do projects that you actually have interest in. Otherwise, it can be a bear to get through. And you certainly don't want to do that to yourself. You want to have things that are interesting. Do things relevant. It doesn't mean you can't have a paper that's outside of surgery or a paper that's outside of surgical specialty, but you can't be all over the place. You have to at least look focused for what you want to do and be mindful when you choose those projects for doing that. EUS, I think, is a little different this year in that there's a space where it's only publications and only referenceable work, and then there's a whole research experience space. So make sure you look at that as well. And then finally, personal statements should be personal. They should reflect you. Don't AI or template or do something that's safe. Do something that's you. That's program directors may be their only window to learn about you. So make it meaningful and make it memorable. All right, I'm finishing up my time here. The take-home points is for this, start early, but get it right. You have to be 100% sure that you want to do this. It is a big commitment, but again, the rewards are absolutely unmatchable. And once you've made that decision, start on all the things we talked about. The most important metric of all of it, whether you're thinking about specialty with geography or pay or procedures or family, which are all important, but the only one that's the most important is for the rest of your life when the alarm goes off in the morning. You got to wake up and look forward to what you're doing. You got to be happy. So do your homework and then don't listen to sentences that start with what program directors want because every program director wants something different. So anything that starts with that sentence by default is not an accurate statement. That is just a little bit of window. We can talk all night, but there's a lot of other people I want you to hear from who are going to talk about other subjects. I'm happy to hit the Q&A at the end of the session.
Actually, Dr. Dort, that was amazing. We actually have at least one question in the chat that we thought we have a couple minutes to answer. There was a question how do you recommend for the students to ask attendings to be their mentors given their hectic schedule? What would your approach be?
It's a great question, and it can be a little bit intimidating. And the reason I think it's a great question, I think that's what leads to under mentoring. I think attendings assume that why don't students ask me? Why don't they come up and get some time? That's what they're thinking. And you're thinking they're so busy and it's just me. And the ones who are in education, the ones who want to teach, the one who parts of, they're looking for it. Be brave. Just go up and say, hey, this is what I'm interested in. I've really enjoyed, you've had some great advice. I've really enjoyed listening and learning from you. Is it possible at all for me to get a few minutes just to talk about my application? I can't imagine. It's so rare that someone would say no to you and not sit down and do that. All you have to do is just summon up that courage, but I think you're going to get a positive response.
I'm going to ask you a question, Dr. Dort.
Ma'am.
So it's totally along that line, which is a great question. What do you tell your student to get prepared for? Because you can't give good advice unless you know the student, right? And so what's your advice to that student to get prepped for that meeting where the mentor may not have so much time?
It's a great question. Think before you go into the meeting, think of what you want to walk out of the meeting with. Think about your endpoints and focus that conversation. Some of them are, as soon as you get them started, they're just going to go with the advice and they're gonna tell you everything that they want to tell you. But have in your mind, these are the goals I want to walk out with, which can be anything to what do you think I'm competitive in, where and what do you think I should do for research, what should I set up for an elective? Should I do an away elective? I know there's a talk coming up about that piece of it. How do and who do I signal? Which there's another talk you're going to hear about for that. But think in your mind what you want to walk away with. Don't just walk in and let the tides take it wherever it's going to take it. Make sure you decide what you want out of it. And where the conversation goes, at some point they're going to look at you and it's going to be your turn to speak again and just have prepared and practiced to be on target with what you want to ask.
Well, that's excellent advice. Thank you so much.
Sure.
All right, next we have up is Dr. Rana Higgins. She's from the Medical College of Wisconsin. She's another passionate educator, program director, and I'll let you go ahead and tell us how to become a competitive applicant.
Great. Thank you guys so much for having me. On behalf of the SAGES Raft Committee, thank you all for being here, and thank you so much to the panelists and to Betty for putting all this together. So really enjoyed Dr. Dort's talk. I am not going to tell you what exactly I want as a program director, because I completely agree with him that every program director has different perspectives. I'm going to try to provide you with some objective, data-driven information. Being surgeons, we of course have to provide you, talk about all of that, to really define for you what makes a competitive surgical residency applicant. And I will put some of my own perspective in there as well, but I really wanted to show you what the data shows so far. So these are my disclosures, none of which are relevant to what I'm going to be talking to you all today about. So what does competitive mean? Really, the idea behind competitive is how do you maximize your odds of matching? And as Dr. Dort mentioned, it's not just matching to match, it's matching at the place that you want to match with the type of training that you want to have. And so really the buckets that you want to think about this are really 5 main areas. So a competitive applicant, and when I meet with students, I talk to them about this as well, looking at board scores, looking at research, looking at clinical grades, letters of recommendation, and then fit and personality. And we'll kind of talk about how all of those weave into your competitiveness. And how competitive you are at one program is going to be different than how competitive you are at another program, which was his point about not every program director wants the same things. Not every applicant wants the same thing. So that's where the data can kind of help you. And there's tons of really great resources online where you can find a lot of this information about what a competitive applicant is at each of these programs that you're applying to, that you can add to the big spreadsheet that you're making. So this was a study from 2022, the Journal of Surgical Education, evaluating predictors for successful residency match in general surgery. And the purpose of this study was to determine predictive factors among all applicants between 2018 and 2021. And you'll see why I split this talk up into 2 parts, because this part of the talk really focuses on the more traditional way that we used to interview applicants back in the era of when all interviews were in person. So in this study, they basically looked at a plethora of residency applicants through the NRMP, and they looked at the data, and I'm just going to highlight for you some of the main takeaways in terms of matched and unmatched applicants. So when looking at number of honored clerkships, matched applicants had almost 4 versus 3 compared to unmatched. Honors in general surgery was very important. You could see almost 2/3 of matched applicants had honors in their general surgery rotation. AOA, you can kind of take it or leave it. Some institutions don't offer AOA, so I'm curious to see what the other program directors say, but I think it's just another metric of excellence, like the Gold Humanism Society. But I think more importantly are the grades on the clinical clerkships, and specifically on general surgery. This is a challenge, though, because there are some schools where it's pass-fail. So we completely understand that as program directors. And so the data is heterogeneous, where we understand that not every school has the traditional honors pathway. Step 2 is very important. So as you all know, step 1 became pass-fail. You can see on this study, they did look at the step 1 scores, which are not relevant anymore because now it's pass-fail. Step 2, you can see matched applicants had a higher mean step 2 score at 251 compared to unmatched at 245. The research aspect that was being talked about, 5 compared to 4. I mean, these are all very, very tight numbers. I'll show you some updated data, but you can see that the pattern is that grades matter, the board scores matter, research activity matters, and then overall, those who matched, as you can imagine, had more average number of interviews, around 14 compared to 10 for those who were not matched. They did a logistic regression in this study also to just look at really the sensitivity. And you could see, again, step 1 not really relevant because now it's pass-fail. But you can see there was a greater odds, almost a 2 times odds for those who scored above 252 on step 2 in matching, honoring more clerkships, honoring general surgery, AOA. So all of these things demonstrating academic excellence really highlights a competitiveness in terms of matching in general surgery. Here we also see about research, so more abstracts, more publications, all of those things in terms of research productivity. And I'll kind of flesh out what that means exactly, but research productivity is important. So this is just a graphical representation of that logistic regression. So you can see the things that mattered in this study, AOA, which again, I think you can kind of take or leave that. But more importantly, step 2, honoring clerkship, specifically honoring general surgery, and then the number of publications here, but more so research productivity, I would say, is what is most important. So from this study, and the reason they did this study was because step 1 transitioned to pass fail. So what were the other metrics that were important? So step 2, research productivity and clerkships, I think are the main things from this study that were important and that really do carry over into today. So 2 things have changed amongst general surgery residency applications and matching since that time. One is the pandemic, which led to a significant amount of virtual interviews, the majority of which are still being conducted virtually, though some programs are doing in person, some are doing kind of a hybrid. And then the introduction also, 2 major things, program signals and geographic preferences. So that study I showed you before really does not take into account virtual interviews, does not take into account signals, and does not take into account geographic preferences. So a lot has changed in the last few years. So just to give you a timeline for those of you students who are like, what is she talking about? So in 2020, we had the pandemic. Everyone remembers that. And interviews were exclusively converted to a virtual format. Now, as I've mentioned, some programs have changed. And then from 2022 through 2024 match cycles, the AAMC provided general surgery with 5 preference signals. So applicants could signal 5 programs if they were interested. And then in the 2023 match, they introduced geographic preferences where applicants can select 3 of 7 to 9 locations across the US in terms of geography that they're interested in. And then in 2025, so we've now completed 2 match cycles with 15 preference signals, which seems to be where it's going to stay for now. In most recent discussions with the APDS. So signals have now become a really large part of all of that. So I wanted to review some of the more updated data. So just so you know, all of this data is publicly available. The NRMP releases this data every 2 years. So this is from 2024, in August of 2024. So in August of 2026, the NRMP will be releasing an updated set of data that anyone can publicly access and view. And so this provides charting outcomes for those matching into their preferred specialty. And if as a student you don't have access, you can ask your dean or your medical school. They can absolutely get you access to this information, and you should know this information. So I'm going to talk primarily about MD seniors. There's a lot of data in this document about IMG seniors. There's also IMG graduates. There's DO. There's also those who are MD and who have graduated. But just for the purpose of this talk, I'm going to focus on MD seniors since that's the majority of those applying to general surgery. So if you look at match rates, again, this is from 2024, you can see general surgery for MD seniors. So those who were senior medical students at the time at which they applied to general surgery residency had a match rate of 82%. And this shows you the statistics for US MD seniors. Again, this table will look different for IMGs, for DOs, for those MD students who have previously graduated. Like I said, it's a very useful set of data to look at. But I just wanted to highlight a couple of things here that really tie into what I was previously saying about competitiveness that we saw from the previous study. You can see the mean USMLE Step 2 score for those matched back. This is from 2024 data, was 253 compared to 238 unmatched. You can see the number of abstracts, presentations, and publications. So we know that as medical students, it takes a long time to get a publication. And of course, unless you're an MD, PhD, we don't anticipate you're going to have 10, 11, 12 publications, but it's all about the research product. So abstracts, presentations, publications, all of those things. Typically, we want to see more of that. And that, again, indicates academic productivity. And you can see that's around 11 for those who matched compared to 7 who've unmatched. And then if you look again, this document is very helpful because it not only does it show you the average, but it will show you the distribution of all of this data. So you can see here step 2 scores. I mentioned according to this, a competitive score for matching would be above 253 average. And you can see here the between 251 and greater than 260 form the majority, but the 241 to 250 category still has a large amount as well. So you don't want to just look at the mean, you want to look at the distribution as well. So really, I tell students between 240 and above, the thing with general surgery is we look very much at the whole applicant, which is different than some other specialties. So a step 2 score, perhaps in the 240s, may not be the strongest score, but can you pull yourself up and elevate yourself with some of the other things I talked about with the research and things like that? So you can see really between 240 and above, relatively strong presence here in terms of match success. In terms of the abstracts, presentations, and publications, I mentioned to you that the mean was 10, but really the vast majority have over 5. And so the more you have, obviously, the better. But you can see if you have minimal research productivity, that can really hurt your chances in terms of matching. One question I often get from students is, does it have to be in surgery? Again, this is just my perspective as program director, but I do not expect everything to be in surgery. I completely understand and know that students can become interested in general surgery at different times in their training. And so for me, especially, I'm at an academic center, so I have that bias, but I just want to see some interest in the scientific process and being a continuous learner and using evidence-based practices, which even if you go into community general surgery is an incredibly important aspect of our field. You have to really evolve with the times. And so I tell the students, really, it's okay that you don't have something in surgery, but once you know that you want to go into surgery, that's where, as was mentioned, finding a mentor, trying to get involved in some surgery research productivity would be valuable, just to show your passion and your interest for the field. But if you've already done a couple years of research not in general surgery, that all still counts. And I do believe that as program directors, the vast majority of us will strongly consider that as well, even if it's not all in general surgery. So in the 2025 match, just to give you updated statistics, there are about 3,500 total applicants for 1,800 positions and 320 categorical programs. So about 1.95 applicants per spot. So very competitive. As I mentioned, the 82% match rate was amongst MD seniors, and that data is available depending on what type of student or graduate that you are. So to summarize everything that I presented to you in terms of the data, but also to incorporate some of my perspective as program director. So board scores, I would say the vast majority of programs do expect a pass on their first attempt of step 1. I think, obviously there's always situations that come into play and issues why someone may not pass the first time. I think if you don't, you need to be transparent about that and the reasons why. But I think that definitely puts you in the competitive category, passing step 1 on the first attempt, and really at least getting a 240 on your step 2. As I mentioned, the higher cohort of students who matched were really in that 240 and above category. For research, participating in research, abstracts, publications, presentations, really at least 7, if you could see from all the data that I provided you, incorporating all of those types, abstracts, publications, and presentations. And just a caveat, this will matter more to some programs than others. As an academic residency program, it matters a lot to us. But again, surgery is a constantly evolving field, and you need to learn how to be engaged in, even if you're not doing scientific research yourself, which most of us are not surgeon scientists, but understanding how to read abstracts, read papers, and the best way to really know how to read them is to have written them and been involved in studies. So that's really the importance of it. It's not because we think everyone's going to be a surgeon scientist. It's because you have to be innovative and you have to stay on top of all of the evidence and the evolution that comes with being a surgeon. Clinical grades, obviously, very important in terms of being competitive. Honors in surgery and other core rotations. Again, the caveat to this is for those medical schools that are pass-fail, which we look at a little bit differently. But if you have that capability, And that ability at your medical school to get in honors in surgery is important. And again, other core rotations like OB-GYN, internal medicine, things like that. I mentioned before at the beginning a couple of other important topics that I hadn't addressed yet, one of which was recommendations, letters of recommendations. So these are important as from my perspective as a program director in making you competitive, if they can attest to your clinical performance as both a junior and a senior medical student. We don't want to see just letters from when you were a junior student. We want to see your evolution, how your clinical aptitude is, and everything like that. And finally, fit and personality. So how do your career aspirations align with what the program can offer? Do you want to take advantage of the research opportunities? What have the former residents been doing and where have they been matching into fellowship? This is all very publicly available data that should be on their website. But if you want to be a pediatric surgeon, you don't want to go to a program that has never matched a resident in pediatric surgery. So you really, as was mentioned by Dr. Dort, have to do some soul searching and figure out what you want and see what does the program offer you. And how do you fit with the culture of the residents? If it's a virtual interview, a lot of places will do a virtual social, a meet and greet. A lot of programs who do virtual interviews offer a second look day. So you just want to make sure that the culture of the residency fits you as well, because 5 to 7 years is a long time, and it's as important that you feel that it's a good fit for you. Behavioral attributes that are really important to us because there's so many applicants that we get, but the way that we can tell some behavioral attributes which can contribute to competitiveness are the letters of recommendation that I mentioned, as was discussed, the personal statement, and the interview. The interview is a very important way to glean behavioral attributes that would make someone competitive for that specific program, meaning would they be a good fit for that program? So some of the adjectives that come up are taking initiative, being self-motivated, being thoughtful, intellectually curious, self-aware, strong communication skills, maturity, and work ethic. These are all the things that we're trying to get from the interview. And does that align with what the program has? And is that a good fit both ways? So in conclusion, competitiveness, there are many aspects of your residency application that make you competitive. This includes board scores, research, clinical grades, which really remain the foundation of any strong application, but there are other important factors. There's fit, there's personality, there's behavioral attributes. These come through in your interview, in your letters of recommendation, and your personal statement. And most importantly, you have to be yourself. You really want to use your application and your interview to highlight your strengths and what makes you unique. No one has a perfect application and no program is perfect. So you just have to find the right fit. And that's really the whole intent of all of it. So thank you so much again for having me. Really happy to be here and happy to take any questions either now or later on.
Dr. Higgins, that was amazing. Thank you so much. I did want to ask one quick question that I get quite a bit. In terms of letters of recommendation, students ask all the time, do you guys like to see letters of recommendation from our research faculty or people who may know us really well but may not be surgeons? What's your opinion on that?
Yeah, I think if somebody knows you well, that is a far better letter than a superficial letter from somebody who doesn't know you well. I think the tricky thing is if it's somebody who's in a different surgical specialty, you have to be a little careful that it's very crystal clear in your application that this person is committed to general surgery, even though they did orthopedic research or OB-GYN research or ENT research, but this student is very committed to general surgery. You just don't want to give any sort of suggestion that you're potentially dual applying. There's no way for program directors to know, but they may see that as a potential red flag. So I would say, most importantly, somebody who knows you well, better than superficial letters. And if it is from a surgical specialty that's not general surgery, just make sure it's very clear in the letter that they write about you that you are 100% committed to general surgery.
Thanks, Dr. Higgins. There's some other questions, but we'll circle back to them in the Q&A just to keep us on time.
Great, thank you.
Really sound advice. Thanks, Dr. Higgins. Always good to see objective data. Next up, we have Dr. Brian Smith. He's the program director of UC Irvine, and also he's also the program director of the MIS Fellowship. And I think this is a really important topic, is it myth or reality of the benefit of audition rotation? So thanks, Brian.
Thank you, Dr. Peterson. Thank you for having me. I appreciate the opportunity to chat with everybody about this. I know this question certainly comes up around our shop every year, and the students sometimes struggle because different faculty give different opinions or advice about away rotations. And so I will preface this talk by stating that if you line up 5 educators, you're probably going to get 5 slightly different answers. And so I'm going to try to be as objective as possible, but may divulge some of my own bias in the process. So let's take a balanced look at away rotations, both the pluses and the minuses, and how it may affect your ability to match in general surgery. So what is an audition rotation? Well, it's a surgical sub-internship. It's a sub-I. And these terms are interchangeable. I think audition rotations have become a little bit more fashionable as the title has evolved over time, but it's a 4-week intern level clinical rotation during your 4th year of medical school. What does an intern level clinical rotation means? It means you're functioning at the level of an intern. You're functioning like an additional intern on the service, hence the name sub-internship. In that role, your job is to carry your own patients, much like an intern does. You're going to have some number of assigned patients that are on the inpatient service. You're going to write their daily progress notes. You will hopefully have a chance to enter orders, so you get some experience with order entry into your electronic medical record, and to be able to present those patients on rounds in an independent fashion. That means you need to know the patients backwards and forwards, which is one of the points that I'm going to highlight a little bit later in this talk. It can be done in 2 different settings. It can be done at your home institution, or it can be done as an away rotation. And I think it's mostly a given that people do home institution audition rotations or surgical sub-Is, but the variability in terms of advice that you'll get from educators is about the value or the importance of doing an away rotation, ideally at a target program, a program you're interested in for one reason or another. And lastly, it really provides direct exposure to surgical culture in general. It gives you an opportunity to work closely with faculty that otherwise you may not necessarily be as close with or have as much face time with as you do during your 3rd year clerkships. And perhaps most importantly, it gives you face time with the residents. I am speaking for my own program, but I feel pretty comfortable stating that at most programs, residents have a meaningful contribution into who we recruit. At UC Irvine, the residents have a major contribution to who does, and perhaps even more importantly, who does not join our family of residents, because our program is very much like a tight-knit family. So you can think of an audition rotation or a sub-I as a working audition. It's an opportunity for you to audition for the program, but it's really also an opportunity for the program to let you audition and form their own opinions about your clinical performance, your aptitude, your knowledge base, and what you're capable of doing. So why even consider this? Well, perhaps the most important reason is that general surgery is pretty competitive. Over the last more than a decade now, I have, as program director, an additional 5 as an APD. The trend that I have found, and I'll let perhaps the rest of my panelists chime in at some point about this, but what we're finding is that as neurosurgery, orthopedics, ENT, plastics, and now even OBGYN are becoming increasingly competitive, the specialty that people pivot to, if they are not competitive enough for one of those, or more often when they apply to but don't match into one of those 5 surgical subspecialties, inevitably students pivot back to general surgery, and it is increasing the competitiveness of general surgery. So back in the 2024 match, there were 1,490 categorical positions back in 2024 for the 2025 match. 96% fill rate, which puts it in the category of one of the highest of all surgical specialties in terms of competitiveness. The average step 2 score for U.S. medical graduates or seniors that applied and matched was 252 on their step two. And the average number of programs ranked by those that matched was 13, just to give you some context about what successful applicants generally look like. So when you broaden that question about what are some of the other categories that are important and maybe predictive of matching, you can simply go back and look at match data from 2024. You can see an average score of 252 on step two, as opposed to an average score of 240 for those that went unmatched. Research experiences, and that doesn't necessarily mean publications or presentations. More often than not, that is actual research experience in a lab or working with somebody on a dedicated project, was about 3.5, and it was closer to 2 for those that were unmatched. The average number of programs that were ranked by successful applicants was 13, whereas those that went unmatched had an average number of programs ranked at 6. Not surprisingly, because they arguably had less interviews in the first place. Away rotations completed. The majority that matched had completed rotations away, whereas the minority of those that went unmatched, the minority of those had completed away rotations. I'm not sure you can necessarily consider that cause and effect, but it's certainly an opportunity to consider the importance of an away rotation. And then honors, we've talked a little bit about honors tonight. It is a challenge because there are many schools that don't offer it, but those that had honors under their belt more commonly matched, as opposed to those that went unmatched less commonly had honors under their belt. So let's talk specifically about the case for an away rotation or a sub-I, and why most applicants would strongly recommend it, particularly those that have successfully matched. Well, there's a number of positives. You can really obtain strong letters of recommendation by working directly with faculty who can write specific and impactful letters that talk about specific times where you may have worked with a faculty member or scrubbed with them or been their first assistant or saw patients with them in clinic. And it allows for arguably a stronger letter of recommendation because it's a more meaningful interaction over the course of a month. The importance of your sub-I serving as a true audition cannot be overstated. It's your opportunity to demonstrate your clinical skills, in particular to program leadership. But I want to caution everybody, if you're going to go do an away rotation, it does not need to be on the program director's service. Every year we have a huge number of applicants to come do sub-Is at our shop. And I'm told that the vast majority want to come rotate on my service. It's really not necessary for you to rotate with me specifically because I meet with every sub-I that rotates through our institution. And so I have a sit down with them and I run through their goals and their interests with them. But more importantly, I gather feedback from the folks that the sub-Is do work with, both the residents and the faculty. But the importance of letting that serve as an audition cannot be overstated. It's an excellent networking opportunity. You can build relationships with faculty, but again, perhaps most importantly, with the residents. The residents are oftentimes the ones that are going to really fight for the outstanding sub-interns that come rotate through your institution. A sub-I is a great opportunity to provide you some clarity, help confirm that surgery is the right fit. Let's be honest. Most people have to make decisions about what specialty they're going to choose with really limited and arguably insufficient amount of experience and exposure, because most of that comes from the third year. Someday when I'm the dean, I'm going to have half of your fourth year rotations, your electives are going to occur in the third year so that people can have more opportunities to try different specialties on for size and make sure that they are finding the right fit. But that clarity is an important component of these away rotations. It also allows you to demonstrate your commitment, not just to surgery, but also to the individual program that you are investing this time and energy to do these visiting rotations at. And then lastly, it is an excellent opportunity to increase your application strength. So if somebody chooses to come do an away rotation at our shop, what that means to me is that they are highly interested and committed to our program. Most people can only do one or at most two away rotations during their fourth year of medical school. So when somebody shows that they want to spend that capital in our program, that tells me a lot about their interest in our program. And it also tells me that they're willing to leave their home program and leave the comfort of that in order to create opportunities for themselves to network and try our program on for size. So it says there's a lot of unspoken importance that comes simply from showing up as a sub-I in our shop. So I think all of these make the case for doing away rotations. But it's important that we have a balanced view. And so I want to also talk about the argument against doing sub-ice. It is high stakes. Make no mistake about it. A poor performance by a sub-I can very much leave a lasting negative impression on a program and oftentimes can actually be the kiss of death. If somebody comes and rotates in our shop and underperforms or underwhelms, and nobody advocates for that resident or for that student to join our program as a resident, that says a lot about what I can expect to get from that student if they actually did come as a resident. There is a significant opportunity cost for being gone from your own program for 4 weeks. Board preparation, which has to be squeezed into your fourth year somewhere, research productivity, personal statements, completing your applications, spending time with your family, walking your dog. All the personal aspects of being gone from your home for 4 weeks are not insignificant. There's a financial burden. It's expensive to go away. You have to spend money to apply for away rotations. You usually have to pay for housing on your own. And so you've got between application fees, housing, and then the travel to get to and from. It's a pretty significant investment to do an away rotation, much less two of them. There's a mental fatigue component that comes from being on stage consistently for anywhere between 3 and 5 months during the first part of your fourth year of medical school. The long hours that you generally are expected to put in as a sub-I, and this constant feeling like you're under the microscope, everybody's watching you, you have to be perfect, you have to step up to every opportunity, you need to be everything to everyone, everywhere, all the time. That is exhausting. It's demanding. Many would argue it's great rehearsal for a career in surgery, but nevertheless, it can be taxing. And then you also risk some overexposure. If you do too many away rotations, you may struggle with where you actually want to go. You may inadvertently be telling your home program that you're really not interested in them. And it may tell programs that you do go to that if you're going to go do other sub-Is, that you're really not that committed to them or focused on them. So there are risks, and I don't want people to think that this is a free ride per se. The risks are manageable with some planning, but they are legitimate. So if you stack the pros and the cons at a glance, again, pros, targeted specific letters of recommendation from surgeons, in-person audition at target programs, particularly interactions with the residents, networking, and program insight. You really get to see what a program's about when you spend 4 weeks there on rotation. And I would say, figuratively signals the program that you have a genuine surgical commitment. Whether you need to spend a signal on a program that you do a sub-I at or not varies from program to program. I will just say that historically we had always, or I should say since the inception of signals, we had always told our residents that if they came as a sub-I, they did not need to signal us. They did not need to waste a signal on us. This last year, we had to change that because we really needed to know who was interested and who wasn't. And we wanted to see people be willing to spend that capital on our program if they really wanted to come spend the rest of their residency training with us. And it directly increases interview invite rates at away programs. I've always told students I think it's an excellent opportunity to really go perform well and strut your stuff at another program and let them know that you're very interested in them, and it is very likely that you will get invited for an interview if you go and perform relatively well at another program. But again, the cons, kiss of death, if you show up and you're mediocre, that's not who I want to recruit into my program. I am looking for stars, not just stars, superstars for our program. And so a mediocre performance can really make it very clear to us that you are not a good fit for us, and vice versa. Don't forget the financial cost, the time away from family life and everything else you need to do as a fourth year student, the mental toll and exhaustion that it takes. But in reality, if you're not doing away rotations, you're probably doing home rotations, and those are very much as important as away rotations are. And then you also risk overextending yourself to too many programs. So overall, I would submit that for most applicants, and certainly in my opinion, the benefits outweigh the risks, but you have to be careful in your planning. So, all right, let's say you've decided you're going to do a sub-I. Are you going to do it at home? Or are you going to do it away? Let's be honest. Most of your fourth year rotations, if you don't travel, are going to be home sub-I, home sub-Is. And so there are some real pros to spending your time at home and performing well on your home sub-Is. It doesn't cost much of anything because you're already living there. You don't have application fees. You don't have transportation costs. It's a familiar environment. You know how to get around the hospital. You know where radiology is. You know how to get things done. You know people. It's a much more comfortable and easy environment to flourish in. It generally is much easier for scheduling because your home institution will help arrange your fourth year rotations, and really helps build rapport with the faculty in your own institution, who generally are going to be the backbone of your letters of recommendation. And so those are all significant pros. What are the downsides to doing all or too many sub-Is in your home institution? Well, you're really not getting that audition value you do at other programs. If you're a mediocre applicant in your own program, that may hurt you internally, and you may actually need some away rotations. And there are fewer external networking opportunities. You're not going to get to go meet residents in other programs and have them advocating for you. Your home visiting rotations or your home sub-Is really are ideal for students who want to stay in their home institution or nearby. So now contrast that with away rotations. Again, some of the advantages, auditions at that target program. If your dream program is a program that you may not necessarily be as competitive for based on the details of your application, you going and rotating as a sub-I at that program and absolutely knocking their socks off is an excellent opportunity to increase your chances of an interview there. And again, I'll be interested to see what the rest of the panel thinks. I would submit that once you get an interview, it is an even playing field. Once we have our slate of interviewees each year, it is theirs to gain or lose. And we really look very carefully at the interviews and put everybody pretty much on an even playing field at that point. Away rotations allow you to expand that geographic reach and potentially be competitive at a program where you did not that's nowhere near where you did medical school or where you grew up, but you have an independent interest in. It again really allows you to stand out at these unfamiliar schools who otherwise wouldn't know you from any one of the other 1,500 applicants that they have. And it tends to drive interview invites. Again, our program historically had always invited all of our sub-Is, and we have now had to change that in the last few years. If a sub-I comes and they perform mediocre, they will not necessarily get an interview in our program. And that's simply because of the volume of students we have doing sub-Is in our shop versus the number of interview spots we have and the number of internal applicants from our own medical school. If I interviewed every sub-I and every student from our medical school, that would leave me with very few interview slots left. And so we have had to be more selective about auto invites for those that do sub-Is. The cons of an away rotation, I mentioned before, expensive, unknown environment, you're a bit of a fish out of water, and you really have to perform immediately. You have to hit the ground running. You can't just spend 1 or 2 weeks kind of getting warm and then do well for 2 weeks. That doesn't reflect well and is generally not going to be an attractive quality for a program that's trying you on for size. So away rotations are best for students that have targeted programs outside of their home region that they're specifically interested in. Overall, my recommendation, 1 to 2 strategically chosen away sub-Is is what I recommend and what many people widely recommend. So let's quickly, last couple of slides, look at your MS4 year at a glance. February through March is when you're going to start submitting your applications for an away rotation, and you start looking for housing. July through October, some people would argue that your sub-I season is July, August, and September. I actually would disagree. Depending on when your medical school promotes you from the third year to the fourth year, certainly in our shop, May is their first month as a fourth year student. I encourage all the students, all of our students to take May and get step 2 out of the way. If they spend May doing step 2, that leaves June, July, August, September, and October. I would argue 5 months for sub-I rotations. And I recommend to our own students go do 2 aways and 3 in-house. And I recommend that they do 1 or 2 in-house to start so that they can get seasoned and well-oiled and are ready to really shine when they go do their away sub-I rotations at their target programs. Now, if you're going to use your sub-Is to obtain letters of recommendation, you're really only talking about June, July, and August as the months where you're going to be able to ask for a letter because letters are due shortly thereafter. However, September and October are pre-interview, and those are excellent months to be under my nose, working in my shop, having people chirping in my ear about what a fantastic sub-I you are as I'm selecting who's going to actually come for an interview. September 1, ERAS open, submit your applications with your sub-I letters of recommendation. So again, September and October are not helpful for contributing to those letters. In October, interview invitations go out, and oftentimes sub-Is are flagged. We start gathering information about how the sub-Is have performed in our institution, and that contributes to whether or not they're going to be invited for an interview. November through January is interview season, and then in February, everybody submits the rank order lists, and sub-I performance very much influences rank order position. In our institution, it is very much influenced by sub-I performance, and that's usually when the residents or select faculty will step up and really advocate for a particular student that is rotated through. So what separates a good sub-I from great ones? Arrive early and stay late. Pretend that this is an audition. Surgical culture in general tends to reward people that show initiative and are consistently present. Nobody expects you to be able to cure cancer or do a Whipple as a sub-I, but they expect you to be present, hungry to learn, easy to teach, be there before rounds, know your patients backwards and forwards. Every single lab, imaging result, plan, you need to know your patients backwards and forwards. And if you're really ambitious, maybe even know the other patients on the service that have not been assigned to you. Make sure you speak up appropriately and offer thoughtful and concise answers about what's going on with your patient. Make sure you're reading about what's going on with your patient. Seek feedback mid-rotation, 2 weeks into the rotation. Ask people how you're doing. Look for opportunities to improve so that you don't find out that you have been lacking in some areas at the end of the rotation. Ask for your letters of recommendation proactively if you're going to obtain some from your sub-I, and make sure above and beyond everything else you are constantly a quintessential professional. Reputation is absolutely what helps build credibility both inside and outside of the operating room. So I think this is my final slide, but to remember, highly competitive field, CK2 or step 2, clinical knowledge is now really our only objective measure of your knowledge base. And so you should aim for above 250. A well-executed sub-I is perhaps one of the highest returns on investment. It drives letters of rec, networking, and interview invites. 1 to 2 strategic away sub-Is is a standard recommendation from many educators, although again, you will hear some differing opinions. And the risks are real, but they're manageable. Plan on the finances where you're going to go and make sure that you show up and you're ready to shine. The sub-I is your audition, so make sure you make it count. Plan early, get your VSAS application in March. Make sure that you do well on step 2. I recommend you take it in May or June as soon as you advance to the fourth year, and make sure that you build relationships, not just show up for a rotation.
Fantastic. Very frank and very helpful, Dr. Smith. I think what we can do is Dr. Jackson, you think we can do a Q&A at the end for the one question and then
Yeah, I'll make sure it gets asked at the end just so we can
okay.
move it.
Maybe and I know we're a little bit over, but should we do a little rapid fire real quick of the varying programs? Okay, so who interviews all their sub-Is? Raise your hand at the various institutions. Okay, do you, Dr. Dort, interview all your sub-Is?
Not 100%, but as Dr. Smith mentioned, I mean, they would have to make an effort to get off that list, and sometimes it happens. But anyone who comes and does reasonably will get interviewed.
Okay, second question, who interviews all their home medical students? Okay. I think it's helpful, and I think that some of the advice, Dr. Smith, is also from the counseling side, which we'll hear from, on the medical student side, on how to match where you go for your away rotation, or how to help guide that decision making. So let's turn it over to Dr. Chris Calhoun. So Dr. Calhoun, she's the director of medical student surgical education and runs the clerkship program at University of Washington. And I think, as you guys have seen, the landscape continues to change. It went from 5 signals now to 15 and 15 for the past 2 years. And I think this is very useful information, Dr. Calhoun, if you can guide us and the students.
Yeah. So thank you for having me. I'm a breast surgeon and I'm a clerkship director. So I am kind of coming at this from a different perspective than some of the other panelists, but hopefully I can shed some light on this. So as mentioned by a couple of the other panelists, signals were introduced in the 2021-2022 match cycle. The goal was really to stop application inflation. We had gradually seen bloat in the number of interview applications. People were putting in 80, 90, 100 applications. There was interview hoarding, and it was really an effort to allow programs to see which candidates were really interested in their programs. From 2021 to 2025 for general surgery, there were 5 signals per applicant. This was looked at, and it was ultimately found to be a number which was too small to interpret whether the applicant was really interested or they just didn't have signals. So in 2025, general surgery switched to 15 signals per applicant. Just to put this into perspective, for other fields, orthopedics has 30, as does urology. Neurosurgery has 25. Otolaryngology has 25. Plastic surgery has 20. Vascular surgery has this hybrid of 30 gold, so you're really, really interested in them, and then 12 silver. You're interested in them, but not as much. And then thoracic has 4. So there recently was a survey from the APDS program, the APDDS, and they had sent out a survey. There were almost 200 of the program, well, 188 programs that replied. And it specifically wanted to look at the impact of signaling on interviews in particular, not necessarily matching, but on interviews. You can see the breakdown. They had a fair number of academically affiliated programs. They were either university affiliated or independent. There were community programs, and there was one program which associated itself as military. And one of the specific questions was, do you require the applicant to signal you in order for them to get an interview? And interestingly, and this is in the 15 signal era, which we are now on our second year of. 44 of the programs said, yes, a signal is required for us to offer the applicant an interview. 144 said no. They also asked some other things which have been mentioned in some of the presentations, geographic and setting preference. We often get questions about this, at least I do as a career counselor. Should I put a geographic preference? Should I put a setting preference? The opportunities for answering was either strongly agree, agree, neutral, disagree, or strongly disagree. And you can see that there were tended towards neutral or agree, that you should. Most people were neutral. You didn't really have to put a geographic preference. You didn't have to put a setting preference, or kind of trended towards agree that maybe you should put a geographic preference. But really, it was kind of all over the board. They looked at sub-interns, so Dr. Smith's presentation, and this also said that it did not specify whether this was an internal to your program or an away, but 26 of the programs said very impactful or extremely impactful. 51 said very impactful. 64 said impactful. 33 said somewhat impactful, and 14 of the programs said it doesn't matter if you do a sub-I. So this is hard data from these 188 programs. So we're starting to try and get some additional information out. So this is what we here experienced last year with signaling. We had 20 students who applied general surgery. We have a large class. We have 270 students. And we basically looked to see how many students signaled programs that they were actually offered interviews on. And it ranged. We had some who only received interviews at programs that they had signaled. And then we had some who didn't have any. Our low ranged from 23% of their interviews were at signaled programs up to 100, but it was really variable. And so we really found that students were still receiving interviews at programs where they did not do signals. So the APDS actually has come out with signal of the 2026-2027 cycle signal recommendations. It's a little bit of a mouthful. And there are some strategies. So there's this 80-10-10 strategy that you may hear from your counselors. And it says that you should really take the bulk of your 15 signals and use 80% of them at programs where you are a reasonable candidate to match. And it's hard sometimes to kind of figure out what is a reasonable program, but you can go on Texas Star, Frida, various web pages, and kind of see what statistics for students who have matched there are, and match them a little bit and kind of pair them with your statistics, your SEP2 score, your grades if you have them, your residency or your research things. You're not really going to see your letters of recommendation, but your strengths, and kind of pair yourself with applicants and see where you would be. And so 80% of your signals, which is 11 to 13, should be at these matchable programs. You then should pick a couple that are true reaches. I don't think I'm going to match there, but I would really love to match there. 10% of those signals should be at these reach programs, and then 10% should be at safe programs. So if you're a really safe candidate, maybe one should be at a reach program, one at a safe program, and the remainder at reasonable programs. If you have some questionable, then maybe you should put a couple more at your safe programs, maybe only one at a reach program, and then the other at reasonable programs. This is where you should actually use your counselors, your career counselors, to help you kind of fashion where this 80-10-10 and the exact hard numbers should be. The APDS also came out with some additional recommendations, and this goes to Dr. Smith's recommendations. They say that every applicant should utilize every single one of your 15 signals, and they should actually be your top 15 programs. You should signal your home institution if you're going to apply to it. If you're going to apply to the away rotations, where you did an away rotation program, you should signal it, and you should use those signals appropriately. What about the outcome? Do we have data? We have some in other fields. So plastic surgery has, again, 2025. There is some published data, and there's a publication that looked at survey data from 2017 to 2025 that clearly found that signaling increased the odds of receiving an interview and matching. In neurosurgery, there was a study of the programs, There were 19 programs in neurosurgery that only interviewed applicants who signaled them. And then other 65 programs, they offered interviews to less than 10% of applicants that did not signal them. And then in otolaryngology, and remember, otolaryngology is one of the 30 signal programs, they showed that the outcomes of matching were dramatically increased if you signaled the program. So these other departments and these other fields have clear data. There is also a kind of a combined study which looked at 2023 ERIS data, and it looked at 9 fields that had signals: anesthesiology, adult neurology, dermatology, general surgery. This was in the era of 5 signals, just keep this in mind: internal medicine, neurosurgery, pediatrics, PM&R, and psychiatry. And what they found is when they looked at data, that applicants were 2.7 to 9 times more likely to receive an interview if they signaled a program. General surgery, and this was in the era of 5 signals, was the lowest, but again, even in the era of 5 signals, you were more likely to receive an interview if you had signaled a program. But this is pre-15 signals. So what about now? We've lived under it for 2 years. We actually don't know, because we don't have any of this mature data. And as Dr. Higgins mentioned, the NRMP releases data in 2-year batch cycles. We have 2024 data. That was the last year of 5 signals. We don't have mature data, and we don't really have any data except for some single institution data of 15 signals. So it makes it really hard for us career counselors to tell students. So we can look at our home institution data, we can kind of guesstimate, but it is a little bit challenging to say what is the exact impact. We can look at other institutions and other fields, but we're a little bit in a data-free zone right now. But I think that there are some recommendations that we can make. And so for the 2026-27 cycle, what I'm telling my students and what I would counsel individuals, use every single one of your signals. Use all 15. Don't leave any of them behind. Signal your 15 top programs and employ this 80-10-10 strategy. Use your bulk of your signals at reasonable programs where you're competitive based on your statistics. And this is going to be somewhere between 11 and 13 of your signals. Reach for 10%. This is going to be 1 to 2% of your programs, depending on how you are in your strength as an applicant. This is a program that maybe on the release data, you don't quite have the step 2 score, or you don't have the number of publications, but you really, really like the program and you would love to be there. It's your dream program. Signal them. The worst thing that happens is you don't get an interview. Then put a couple safe programs. Maybe it's an away rotation that I'm pretty sure I'm going to match there. Put it on. So that should be 1 to 2 of your programs. Don't leave signals on the board. Signal your home program if you're going to apply there. Signal any away rotation if you're going to apply there. And for now, we're not in the era for like orthopedics, otolaryngology, urology, where in those fields, they are actually recommending that students not put in many more applications than the number of signals. So this is where we get to this application bloat and the dramatically increased number of applications. We are hoping that with increased number of signals, we will see the number of applications drop down. I don't know that we will be able to do it with general surgery, and it's a supply and demand phenomena. We have 355 plus general surgery programs, and if you have only 15 signals, I think that is a little bit risky if you only put in 15 applications for your 15 signals. So right now, what we are still recommending to students, and it's based on the data that students are clearly still receiving interview offers from non-signaled programs, that you still do put in applications to programs that you have not signaled, but that you do put in your signaled programs to the programs that you really are most interested in. I think maybe we'll increase the number of signals in general surgery. Who knows? I haven't heard any chatter about that, but I think if we truly want to get away from increased numbers and high numbers of applications, we will, in general surgery, have to increase the number of signals also. And that is my talk. So I think I was a little bit more succinct, but happy to answer any questions now or at the Q&A later.
We have so many questions for you, Dr. Calhoun. We're right at the limit of time, and I think that we need to address dual applications in the Q&A, and maybe geographic preference with the panel. So let's go on to our last speaker, Dr. Saurabh Khandelwal. He's again, or not again, you guys haven't met him yet. He's one of our associate program directors. He's also one of the associate directors for our MIS fellowship. And he's really the go-to for our very large preliminary program and does a lot of counseling and strategy with our prelim residents as well. So very successful in getting our prelim residents categorical positions. So thanks for speaking to us, Dr. Khandelwal.
Good afternoon, everybody. Give me 1 second to get that going. Can you all see my screen?
Yep, but just switch it again, your display setting. There you go.
Okay, perfect. Again, thank you, Dr. Peterson, Dr. Jackson, for the opportunity to participate in this panel. I think this is really great advice that you guys are all sharing with these prospective students. Today, I'm going to be talking about the interview, or I'll say how to shine in the interview, because this is essentially the differentiating factor once you've gotten through the gate. I have no disclosures for this talk. A little bit of information. Some of this has been highlighted, but there's a couple important things to note. So there's about 1,800 categorical positions and another 1,000 to 1,200 prelim positions in the United States annually. And for those positions, the vast majority of the interviews are still held in a virtual only fashion. Up to about a third of programs may offer or incorporate an in-person feature, which could be a true hybrid where they're doing both in-person and virtual interviews, or a virtual interview with a second look opportunity. And frequently, if that's ordered, that second look opportunity is done after the rank list has been submitted to reduce bias. The AAMC still recommends programs remain virtual to maintain equity and reduce financial burdens for students who would need to travel to each of those institutions. However, the APDS, their suggestions are to align an institution's practices with its needs, cultures, and values to do what makes sense for them. This has been surveyed. The majority of applicants prefer virtual for those reasons that I mentioned. However, from a faculty standpoint, essentially 100% prefer in-person. And a lot of this is to really gain the nuance and understand the interactions that people have with one another as they're coming to your institution. So what's the goal of the interview? If you think of the application that you spend time putting together, that showcases hard skills and accomplishments, what you did. And the interview is really to help people understand the soft skills that you have, how you did those things. And why are these important? Because these are the skills that are tied to human connection, leadership, working with others. All of these are critically important qualities for surgeons. So what are we trying to assess? We want to see how you interact with us, how you reason, how you communicate, looking for emotional intelligence and how you read the room. How do you listen and can you think on your feet? Again, as I mentioned before, if you got an interview, you're academically qualified for that program. What the interview process is trying to do is evaluate what would it be like to work with you for 5 to 7 years, and vice versa. You're trying to figure out the same thing with each program. How do programs structure interviews? This has changed quite a bit. And a lot of programs have moved toward standardized questions and scenarios. And these are really considered best practices, which have a foundation in the business world. And why are we trying to head toward this way of interviewing? It can often reduce bias between rooms. You can be in multiple rooms in a given day. It can reduce bias between different interviewers, as well as the different dates that a program interviews. What happens in the beginning of interview season can feel different than towards the end. And just to make sure that interviewees like yourselves are aware, Often, depending on a program strategy, interviewers are interviewing the day of the interview, may be blinded from all or parts of your application. So don't get upset if you feel like they don't know anything about you. It's likely very intentional. Rest assured, others have already reviewed your errors file, and that's the reason why you're there. As I mentioned before, the standardized questions and scenarios really kind of focus on the framework or these categories that you see here. And if you look through all of these, they all essentially relate to how do you work with and relate with other people in a variety of situations. And that's what a residency and being a surgeon is, right? Constant new challenges, new people, new situations. And that's what we're trying to figure out to some extent with these interviews. Besides those categories, a lot of programs will have some additional questions, or they may have more of a unscripted session, often with a program director. We'll often use this time to elaborate on your written application, where we might ask someone to give us more information or tell us more about a particular research experience, volunteer work, or leadership role that they mentioned in their ERIS application. We're also very interested in helping us learn about your future goals. Do they align with our program? Why are you interested in a particular program? What would you do with a clinical and research opportunity if you were to match here? And we're also trying to figure out, are your goals realistic in scope and understanding? And this is a pretty tall order to get to know someone, break the ice, and try to get to the root of some of these important questions in sometimes what's only about 15 or 20 minutes with a particular faculty member or resident who may be participating in the interview process. So how do you prepare? None of this is particularly complicated, especially for people who've done other work or had jobs in forward-facing roles with other people. Do mock interviews in preparation. A lot of medical schools can help with this. You can ask residents and faculty that you know to help you prepare for these things. As I said, a lot of medical schools often do this as part of the ways that they assist their senior medical students as they're trying to match. And going back to that framework that I mentioned, you ought to think about these concepts ahead of time. Nothing on that list that I showed you should come as a surprise. You may be asked to give an example where you encountered one of those concepts. And it's okay to say, hey, I've not had a specific instance of that, but this is what I would do in that situation. We're seeing, can you think on your feet? And you're trying to help us understand what would you do in a particular situation. You should obviously do your homework, know about the program, know about your interviewers, understand your own application. We'll often ask people to elaborate on something that they highlighted in their ERIS application, whether it was a research endeavor, a paper, or an experience. And it can be incredibly damaging when we find out or we get the sense that what was emphasized in ERIS either unfamiliar with, or it actually doesn't seem to carry the weight or significance that it was given in the paper application. So know yourself, know your application cold. Common sense things, kind of housekeeping. You should have a good Zoom setup with a good background, good lighting. Make sure your AV and internet connections are all working. These little things can often add a lot of undue stress to an interview day when things don't go the way that you want them to. Unlike how I'm dressed today, always dress professionally, maintain good eye contact, and really get engaged. Zoom is a very artificial environment. A lot of people wish it would go away. We understand the convenience of it. So it's that much harder to make a connection and show engagement. So you want to make sure all these things are set up for you to succeed that way. So when an interview goes well, what are some common themes? We are looking at authentic, mature responses, responses to questions and queries that are thorough. They demonstrate understanding of the question and the concept, and people understand with depth and also get to the point. It's important for us to see alignment with what you're saying with your written application, your letters of recommendation, and your goals. And it's very much a two-way street. We're learning about you, you're learning about us and the program, and the goal is for everyone to come away with a better understanding of each other. When things don't go well, we often see these things, superficial responses, people wasting their own time with empty words. That phrase, they spoke a lot but didn't say much. Sometimes not answering what is being asked or kind of missing the boat. So kind of a callback technique where you summarize the question that you were asked to make sure that you are answering the right one is an important tool to use sometimes. Not being prepared for frequent questions of what questions you have about our program. We've had people say, no, I'm good, I don't have any questions. And it really comes across as someone being disinterested, lacking engagement and preparation for that particular day. Obviously, coming across as insincere or dishonest can be a very significant concern. And as I said before, be consistent. Speak the truth. Tell us what you feel. You'll often get asked similar questions between different rooms, and we're discussing what people say. And when we find discrepancies, that often brings our antenna up. What you see to the left there is a bullshit detector, and I think anyone who's been doing it in education has a pretty good one of these. We kind of know it when we see it. So we're looking for people to show us their authentic selves, and it's pretty easy to see one that's not coming across. Putting it all together, what is a program really trying to get to? They want to understand, does this person understand what it truly means to train in general surgery and hopefully specifically at their program? Do they have good reasons for wanting to enter this field that are specific and authentic? Are their goals just as easily fulfilled in another specialty? Because I think actually contrary to what Dr. Dort said, you'll see a lot of educators actually say you should only go into general surgery if nothing else would make you happier. So when people say, I want to help people or I want to work with my hands, there's many different ways to do that. But we really want to know, why do you want to be training in general surgery? And what is a program trying to do? They're trying to put together a community. Every program has a culture. And when we're interviewing people, we're trying to answer the question, how would this person contribute to our program and our community? And do their interests align with our offerings and expectations? And these are really common themes that would matter at any job interview for any professional role. To kind of wrap it up, know yourself, show yourself, be yourself. And we're looking for consistency between the written application, what you're saying to us, and what people have said about you. Other parts of an interview or part of the structure of engagement could be informal sessions the night before with residents, kind of a meet and greet or a social. There's the Zoom hangout room, which is, kind of going throughout the day as you're being pulled in and out of rooms. And everyone's watching what everyone's doing. Always treat admin and other staff just like you would treat any of us. It shows your character. The death knell of an applicant is someone who is acting one way to someone who's interviewing them and then treating others poorly in the admin or staff roles. As I said before, every part of the interaction is part of the picture that you're putting together for yourself and about yourself. To kind of close it out, this is just kind of old school etiquette, but a lot of us appreciate it. A short email, word of thanks is almost always appreciated. Understand that it may not necessarily be replied to because a lot of programs have a no contact policy once interviews are done. So don't take it as you're being ignored, but do recognize that your efforts to reach out and convey your interests are noted. So with that, I'll wrap it up. Thank you.
It was
Thank you.
awesome. Thanks,
All right,
Dr. Khandelwal.
Dr. Jackson, you want to charge the Q&A?
Yeah, I mean, I think, well, just since we were just talking about the interview, there's a question, not in the chat, but kind of one of our previously submitted ones that I think is relevant to the interview talk. Since a lot of programs are still doing virtual interviews, there's a question about, how do you feel like students can best convey their personality through the screen or demonstrate fit through a computer screen? I get this question a lot, actually. So curious as to everyone's thoughts. If we're interviewing applicants virtually, how can they make themselves known to us?
Open it to the panel, or do you want me to,
Yeah,
take a step?
you can go to the panel, or you can start.
Yeah, let's go to the panel.
I mentioned in the Q&A that charisma counts. And unfortunately, it counts even more when we're doing virtual interviews. I think shy, introverted applicants oftentimes really struggle to shine through, to show their personality on Zoom. And those folks probably need to do some practice interviews ahead of time. It can be a real challenge. It is an absolutely imperfect art. And I'm not sure I have any real wisdom other than come out of your shell and show us some personality.
I'll piggyback to what Dr. Smith talked about auditions and away rotations. There are people who are quite understated people who do great work, and over the course of a couple of weeks or a month, as a sub-I, really may demonstrate how good they are. But they're also sometimes the same people for whom a virtual interview process or a short term of engagement is not their most favorable avenue.
Don't read from the screen. We can tell. And I think the other thing, if you're introverted or, I think that there's a way to push yourself outside your comfort zone with the mock interviews, but also I really respect when the student is, hey, I know we only have 1 minute left. They're very cognizant of the amount of time you have to interview. Many of us interview 15 minutes without a lavatory break straight through, 25 applicants. So it's be respectful of the time. And I agree. I think you're going to be every person who interviews you is going to say, well, what questions do you have for me? So even if it's the same question, just do your homework on the program. We know if you know our program. You have 15 signals, definitely dive deep on those 15 signals. And I think that you can get really honest feedback from someone who you trust, who is just going to tell you that you really need to improve your interview, how you smile, come across. I mean, it's all superficial, but push it to take that feedback not as a critical viewpoint. It's just you have 5 minutes to shine and put yourself out there.
Yeah, I would agree. I would say, introverted, extroverted, all sorts of personalities are needed to be surgeons. We can't all be extroverted personalities. So I think that the biggest thing I would just reiterate what Dr. Peterson said is be genuine about your interest in the program and do your research. I think regardless of the personality, we want to see people who are engaged and interested in the program for the right reasons and who've really done their own research. So I think that's a way you can stand out for sure and show that you're very interested in the program.
And I would just add before we move on to the next question that sometimes your medical school will offer like mock virtual interviews. And so sometimes that's a really great opportunity for you to test out with people that you know at your institution and ask them specifically afterwards, like, how am I coming across? Did I seem nervous? How was my cadence, et cetera? And that can be really helpful insight as you go forth and actually start your formal interviews. Going to the Q&A box, Dr. Higgins, I think this question came in during your talk, but anyone can feel free to answer. So for applicants committed to academic general surgery who fall below one of the typical metrics, such as step 2 greater than 240, or if you didn't get an honors in surgery, what parts of the application can kind of best contextualize this and help to keep residents still competitive?
Yeah, I mean, I would just say that obviously all of these are just data points, but it doesn't capture the whole person. And I do think in general surgery, we do a nice job of this holistic review, which I think, the term gets used a lot, but it's really genuine. I mean, I've had plenty of people I've interviewed who've been below 240. I don't think that's a hard cutoff for us. I'm not saying that's true for every program, but I think even if you don't have an honors in surgery or a step 2 above 240, if you're at an institution where there's, high pass honors, even if you're getting a high pass in surgery, I think that's a way to stand out. Like I said, there's some programs where it's just pass fail. So then we can't use the grades. Letters of recommendation, research, impactful experiences, things that make you unique, leadership. I mean, you can't change who you are. So I think you just have to be realistic about the programs you're applying to, as has been discussed. And I think even if you don't hit all of these metrics, there's plenty of programs that might be a really good fit for you. So that's where you have to really do your research. But we do really look at the whole applicant. I really mean that genuinely.
Yeah, I totally agree. Another question there's two questions that are kind of along the same line. What advice does the panel have to fourth year medical students who kind of made the transition or the recognition that they wanted to pursue surgery a little later in the year? So they may not have known. What's your advice to help them best set themselves up for success, or like with getting letters of recommendations, or should they be contextualizing that in their application in any way? What are the thoughts of the panel?
There are two different things that you can put on an application, numbers and words. Numbers are in the form of number of publications and test scores, and those are what they are. I mean, if you haven't been doing general surgery research and you don't, uh, but what you have are words. Tell your story. I think, Dr. Higgins was saying, I think we're all really doing holistic reviews. One, because that's how we get it. Well, very practically, we're just less and less information is available. Scores keep turning to pass fail, grades keep turning to pass fail. Things just disappear. But maybe that's a good thing. I don't know if there's 1 ounce of science showing that any of those metrics predict success as a resident, but it's all we have. But you have words, you have experiences, you have personal statements. Tell your story. Tell why you got to this late. Sometimes that can be the most impactful things because it's really powerful and meaningful that it hit you to that point, and just share it with us. And the places that read it and are motivated by it, you will appeal to. And the places that took one score and didn't read the rest of your application, maybe you don't want to be there anyway. So, look at it as an opportunity that you can tell your story.
Yeah, I would agree. And one of the other things that you all can do, you can think about, what are the core competencies? So several of the panelists kind of gave great talks about how it really doesn't matter if you did research in pediatrics, right? The competency is that you know how to think about a research project and see it through to publication, right? That in an academic surgery program, that's going to be fantastic. So maybe you talk about that in your meaningful experiences, and you talk about how you did this research in pediatrics, but you're looking forward to, and that led to research publications, but you're looking forward to, studying X, Y, and Z in the surgical field. And so you kind of you can contextualize things in that way. And so you're not shying away from your journey as your journey, just as Dr. Dort was saying. You can't change it. That's what makes you special. And so I would lean into that and think about how your journey is going to help you as you move forward in surgery. Anyone else have any other comments about that?
I was just going to bring up, and I'm curious what everyone has to say about this, but I think it's getting more difficult and for us as Dr. Calhoun et al. Are telling the other specialties to dual apply, potentially in another field, right? You're going into neurosurgery, the unmatched rate is very high. So a lot of these applicants are dual applying, and the default, I think a lot of times ends up being general surgery, and general surgery is not by any means a default. And I think us program directors, we're looking at our signals. 15 signals mean very different for a dual applier. That's like, 50, 51, 52. And kind of circling back about you changing your mind later on, but you've done all the research in this field. I think you need to be careful. I think you absolutely need to tell your story so that the faculty committee review doesn't think you're dual applying. All your research is in neuroscience, right? We think you're dual applying to neurosurgery. Not that we think, we suspect how that comes across and where you come out on, the interview list. I do think it's something for us to consider in this era of signaling. What are your thoughts?
I think that's right. And the problem is the numbers, right? There's so many people who are applying that are qualified that if you get a hint of this person is thinking of another field, the bias is towards the person that's living and breathing general surgery. And as Dr. Jackson said, there's an opportunity there that if you came to general surgery a little bit late or through a non-linear path and you've got a good story to tell and you're given the chance to do it, that'll often really make someone want to get to know you. And we've seen people move on rank lists for all sorts of reasons in interviews because they had a great story to tell. But it's tough with those numbers when you get the sense that someone is thinking or really evident they're doing something else as well.
You can't over communicate this enough. You can't. To all the points that were made, don't spend your efforts trying to hide something. Spend your efforts trying to put it out there and explain it. You'll get a lot farther that way.
It's an imperfect system is really what it comes down to. And the landscape keeps on changing. And so you're paying a lot of money to attend your medical school. Take advantage of it. Take advantage of the services that are offered.
A couple of questions still in the chat, and we're also mentioned in the pre-submitted questions for our prelim residents who are specifically applying again for the upcoming application cycle. How can they best reflect their kind of limited 2 to 3 month experience as a prelim during application time? Like, how can they show difference, right? When essentially it'll only be about 3 months between when they start intern year and when it's time to submit application. So what are your recommendations for specifically the prelim applicant to kind of shine and talk about what's different?
Maybe I can answer this. We've got one of the biggest prelim programs in the country. And just to be clear, Dr. Jackson, we're talking about someone who didn't match. It's now March of their M4 year. They've got 2 to 3 months left of med school. They've got a prelim spot and they've got a very short runway to get from the start of their internship to putting another successful ARIS application together.
Correct.
We counsel people, and again, as you said, you paid the tuition, you didn't match, get over it, get the analysis, get the feedback, but line up some very heavy duty, useful rotations, which are going to get you additional contacts that you can reach back to in 5 or 6 weeks to get letters. Surgical ICU, trauma, whatever the specialty is that you're likely to reapply to. I think the reception that M4s get is almost universally a positive one versus, an intern or an MS3 necessarily. So use that opportunity, line up things. It'll make you a better intern. So you hit the ground running and you're not struggling to get yourself organized and just figure out how to be a new doctor. You've got to really start putting that application together a couple of weeks after it didn't match. And as they say, the definition of insanity is to do the same thing again and expect a different outcome. So what differentiates it? Depending on where you're doing your prelim year, you've really got to highlight the clinical experiences that you have and really make sure it comes across in your application that now you're applying as a physician, a young junior physician with experience, which I would almost, if they did well, I would probably prefer any day to a medical student. However, the optics really in a lot of surgical subspecialties don't tend to favor that. So do some useful rotations, tell those letter writers, hey, I'm going to be talking to you in 5 or 6 weeks to approach you for an updated letter of recommendation because I'm applying to this again. And keep those contacts warm when you leave your medical school. Try to get a little bit of an exit sit down with a couple of people for mentoring, and hopefully those are the people that are writing you letters down the road. One other thing I'll add, I would ask for a brutally honest analysis of why you didn't match. I think the worst advice people get, why do you think I didn't match? I don't know, your application looks great to me. Either they don't know what they're talking about or there's something that they don't want to say to you that's a bit uncomfortable, and you've got to push through that discomfort and say, just be brutally honest with me. Tell me what parts of my application likely hindered my interview, how many interviews I got, or how I came across. So use that opportunity as a medical student to lengthen that runway.
They can't answer that. Oh, sorry, go ahead.
Go ahead. Sorry, Dr. Peterson, go ahead.
I think it comes also to a lot of other points. People cannot give you advice unless everything is in front of them. All your scores, all your grades, all your letters. And so if you're asking someone for advice and they don't have that data in front of them, don't trust their advice. That's
And
where
and once
prepping them is important.
and once you do get that meaningful sound advice, digest it, internalize it, digest it, and own it, and put it in your personal statement and be prepared to talk about it. Talk about your shortcomings, what you've recognized in your own shortcomings, what you've heard and been told about your shortcomings, and what you're doing to change that. Own your deficiencies.
Yeah, I would also add, you're coming into orientation at your new program where you're going to be a prelim. That would be a good time to reach out to the program leadership to ask for a meeting early so that they can have you on their radar. You should already be, but they should have you on their radar to understand that you're on a shorter runway, and that shows initiative that you're trying to hit the ground running. And so you can get their assessment of like, why you didn't match and why you're in that situation. And so they can, connect you with key people in the program to help you make sure that you set yourself up for success so that you can, have a strong application the next go round. Dr. Peterson, there are still some questions in the chat. I want to be respectful of people's time. What should we do? You're muted. You're still muted.
Oh, I said, let's do one more. Pick a good one.
Um, so many. I guess there are a few questions about non-traditional applicants. So let's say you're an IMG or you've taken time off after graduation from medical school and you've done maybe 3 years, 4 years, maybe even 5 years away from the clinical space. What would you recommend for those applicants? How should they think about trying to show that they're still competitive applicants and maybe reframe their absence as a strength? What would thoughts be?
We we have actually come up with criteria on how to kind of review our IMG applicants, and we actually had a committee, and then it became more of a GMEC, like UW Medicine wide. And I think one of the biggest things that we look for is interaction with the US system. And that's important because I think that the training is different, and I think how you do that is also hard. But I think that clinically interacting with the system is really important. I don't think publishing more papers is going to get you an interview or a categorical position. And so the way you can do that, as I saw in the Q&A that was submitted before this, is there are some programs that have certification, or you can, whatever you can do. I know there's not a lot of avenues, but really try hard to get that clinical experience, whether it's through observerships or I would focus on clinical interaction and not more abstracts and papers.
This is fantastic advice. Dr. Peterson, you have the final word.
No, I would say this is a really tough process. And as I'm listening to, all the talks, which were phenomenal and excellent and very frank and honest, it reminds us how difficult the pathway is. But at the same point, I'm sitting here thinking it was well worth it. And, if you can end up loving what you do, it's a hard field. You shouldn't do this field unless you love it. And every day, it's tragedy and triumphs. But I think it's worth the hard work and labor, and it pays off. So I want to thank everyone. Good luck to you all. This will obviously be available, and there's a lot of questions we know that weren't answered, but hopefully all the talks hit at some of these really important points.
Thanks, everyone.
Thank you, everyone.
Thanks to the panelists. Everybody.
Have a good night, guys.